All right, we're going to go into some orthopedic wounds, some trauma, lacerations, bites and stings. We've got a couple devices to talk about. We'll talk about a traction splint used for some of these. We'll talk about compartment pressure needle, and we'll talk about some back pain. All right, so the first one we'll talk about is some of our surface wounds. So abrasions, these are a pretty common reason for ER visits. They're usually not that bad by themselves. They're usually associated with some other injuries too. So, not everybody comes in just, oh, I have an abrasion, but sometimes we've got other bigger wounds to deal with also. The word tattooing effect, I've seen this on the exam personally a couple times, and it's not a word we use every day. So I want to introduce that to you. And so if you see it, what it means is if we don't do a good job of good, thorough wound care, some of that debris that's left behind can cause permanent staining or discoloration, like a tattoo. So how do we prevent this? Do good wound care, basically. For wounds, so we had ischemic time, which is about 4 or 6 hours. For wounds, we've got about 6 or 8 hours, and it's not ischemia, but this is some of the changes that start to happen around that time. Somewhere around 6 or 8 hours, bacteria starts to multiply, so increases risk for infection. Also, you get some new skin cells start to move towards that area. They start to migrate and put down a little barrier, a surface, if you will, start to form that early scab or whatnot. And if we've not cleaned that wound already, they can be trapping infection in there. So the 6 or 8 hours is not written in stone, but the take home is you want to address these wounds sooner rather than later. Okay. We've got many different ways we do this. We've got a lot of different wound products. The ENA does not make any distinction or preference one versus the other. You've got a lot of commercial ones too, like Physahex, Physaderm, things like that. All right, so they're not going to ask you a specific one. I will say the one with betadine though is if you do use betadine, you definitely have to irrigate that out thoroughly afterwards. You should not leave any of that brownish discoloration because some of the betadine product, the chemical, can actually delay some wound healing. So betadine requires thorough irrigation afterwards. Amputations. So some of these amputations may look pretty impressive. We need to make sure that we back up and do the ABCs in that order. All right. Now, the one change to that is if you look at that amputation and this person is literally exsanguinating, critical, massively hemorrhaging from it, then we may stop and put the letter C for circulation first and deal with that, which is what the TNCC 8th edition is currently teaching. If you see this massive hemorrhage, you change from ABC to CAB and deal with that first. Okay. Now, that being said, the ENA exam, the CN exam always follows TNCC. As a TNCC instructor, I'll tell you, every scenario in TNCC, whether the practice ones or the checkoff ones, you always assess for massive bleeding first, but in none of the scenarios is it actually there that you have to reverse that. So my impression as far as the CEN, because I'm due to take it in a couple months, my impression is that they're not going to give you a scenario where you have to reverse it because TNCC is not teaching you to do that. In other words, they're giving the students no learning skills or psychomotor to go through that process of dealing with the C first, but you still consider that first, all right? So with this amputated part, what you see here are some numbers. You don't need to memorize them. And it's basically telling us that the sooner we cool these parts off, the longer they're viable to get reimplanted possibly or reattached. We're trying to delay some of that tissue ischemia, okay? Yeah, bacteria may be overgrowing, but at this point, it's an amputated limb. There's no blood flow to the amputated part. I need to slow down that ischemia that's setting up because that could be the reason they can't do the reattachment if it starts to get ischemic. And when you look at who needs reattachment surgery, it's a very case-by-case basis. There's not an absolute rule that says, because of this, they get this. You have to look at their health, their age range, their, can they even make it to rehab, all right? What's the functionality, all these different things. So like a really obvious case of, let's say, reattaching a finger would be like a 20-year-old who's otherwise healthy, has his whole working career ahead of him. Yeah, it's worth it for him. An example of a no-go case or not a good candidate would be like, let's say Granny lost her fingertip in the side rail at a nursing home. All right, does Granny really need that fingertip and the risk of surgery and all that? When she's 85 years old, probably not. So you got a good candidate, you got a less good candidate. As far as tourniquets on this exam, Again, if we see that life-threatening bleeding, a tourniquet would be the first thing we go to. There's different ones out there. They're used differently. They're not going to ask you specifics. Just know that would be your go-to device. If you come in there and that patient is completely hemorrhaging out, you're going to put that tourniquet on there first. All other non-life-threatening bleeding, we'd use the old school American Red Cross first aid standard, which is direct pressure, elevation, pressure point, and then tourniquet. So that's for the non-life-threatening bleeding. All right. And that means you would not have done the CAB for that. You would have done the ABC for that one because it's not life-threatening. The life-threatening, the tourniquet becomes your first intervention, and then you're going through the C and then the AB. Okay. This is a frequent test question. This is a talking point that's has stood the time-tested ages of every trauma lecture, every trauma in-service or Con Ed program is, what do you do with the amputated part? It goes in one plastic bag, and then that goes inside the other one where the ice is. You're not allowing not allowing the amputated part to touch the ice directly. Okay, standard trauma answer for amputated parts. And of course, make sure you label it, make sure it goes with the patient too. Don't lose it. An avulsion is just a deeper injury, usually below the upper levels of the skin. There's this is a very subjective call, what's an avulsion versus what isn't. It's not based on measurements, it's based on just generalizations. One of the concepts with avulsions is, if you were to imagine if you were the provider and want to stitch this thing shut, would it compromise the range of motion? For example, if you lost a chunk of tissue out of your wrist area, like over your wrist bone, and we were to stitch that together, think about how that would restrict the flexibility of that wrist. Okay, and even after it heals, if it lays down scar tissue, it might be kind of restrictive. So avulsions sometimes go to the operating room to be revised. Avulsions sometimes go home with just wet to dry dressings, allowing it to heal up or granulate from the inside out. Okay, so the provider kind of decides what's an avulsion versus, just know once they say it's an avulsion, we're probably doing some alternate technique with it. Okay, we're probably not stitching it closed in the ER. And we can use splints for all these wounds too. Sometimes a splint is to protect the area. Sometimes a splint is to protect the range of motion while something's healing up. Splints aren't just for fractures. They can also be protective devices to protect that area. We got bites and stings. And we've got a whole list of things that can cause these. Sometimes we have to worry about like poisons and venom or allergic reactions. Sometimes we have to worry about diseases that can be transmitted also. And they're also all puncture wounds to some degree. So we have to worry about that and the risk for infection with punctures. So you got a lot of opportunities across the US. Now the ENA knows that they can only ask universal questions. So you're not going to see questions like about the Portuguese man of war, a big jellyfish, because what about the people that work in Montana or in Iowa? Are they likely to ever see one of those? No. What are we all likely to see? Your basic common insects, your dogs and cats, your domestic animals, your snakes. We got snakes all across the US. So the common things happen commonly. And we'll talk about some of these and some of the testing points from them. So dog and cat bites. So cat bites are going to be the highest risk for between the two for infection. Cat bites, one thing that makes them more at risk is they're more puncture wounds, and puncture wounds are always your highest risk scenario versus an open wound. Cats also carry a very specific germ called Pasteurella, which you don't need to memorize for the exam, but just know because they carry this, cat bites, no matter how minor they look, always warrant antibiotics at time of first care, okay? Because they have this super high likelihood of being infected. Dog bites actually don't get infected. They've done controlled studies. Certain dog bites, they had one control group, they got routine wound care and antibiotics. One got routine wound care and no antibiotics. There was no difference in the rates of infection. A lot of it boiled down to the at-home care more than anything. So cat bites get antibiotics. As far as rabies, we're going to consider rabies in our wild animals most likely. Okay, so the exam will not ask you about a dog or cat with rabies because most of the, especially if it's owned by somebody, animal control can go pick it up and monitor it. The wild animals that are always wild, rabbits, raccoons, whatever, you're not able to go catch those and monitor them. They're back off in the woods, they're gone. Okay, so if they give you a wild animal, you're going to say, yep, risk for rabies, consider rabies shots for these ones. Whether we stitch up these animal bites or not, it's a plus or minus decision. If anything is cosmetic, like on a face, a young person, it's going to be closed by somebody. It may be you're calling plastics to come do it, but just the fact that it's a dog bite or an, does not mean that you cannot close it. There's just a good candidate for closure, and there's a not so good candidate. So like a 40-year-old guy with a dog bite on his shin, nope. Wet to dry, you're going home. We're going to clean it. Wet to dry dressings, you're going home. 16-year-old girl, cheerleader, high school, facial, she's getting it closed. Okay. So any provider that says, I don't close dog bites, they're either lazy or they're not looking at the big picture. It's not based upon the mechanism, it's based upon the patient. If we need to give the rabies shots, we're going to give two things actually. They're going to get rabies immune globulin to work right away. That keyword there under immune globulin is the letter I. It works immediately. And the rabies immune globulin, the letter I, also reminds you that it goes infiltrated in or around the wound itself. You're actually putting the RIG, you're actually putting it around the wound to try and block the rabies germ from spreading. You're putting up a barrier, like a blockade, if you will. Right? You do not know about dosing. You don't know about frequency. Just know the immune globulin, the RIG, goes in or around the wound. The rabies toxoid, for longer term protection, that's going to go in a distant muscle. All right. So if the person got a dog bite, okay. If the person got a fox bite on the left hand, the RIG goes in or around the bite wound of the left hand. They also have rabies toxoid ordered. That's going to go far away. So like their right deltoid. What you don't want to do is have the rabies immune globulin mix with the toxoid and inactivate it, okay? Because the RIG is for now, the rabies toxoid is for the ongoing weeks or a month or so down the road. As far as let's mention this now, as far as vaccination goes. So you do need to know the difference between active and passive vaccination, all right? Think of how the two medicines work. Either the immune globulins that work immediately or the toxoids that work delayed, okay? The immune globulins work immediately because your immune system is doing nothing to manufacture antibodies. You're actually putting the antibodies right there at the wound. So that is a passive vaccination. Your immune system is passively involved in this process. If you give someone a toxoid, whether it be rabies toxoid, tetanus toxoid, or your flu vaccine, the protection is not immediate. Why? Because it's tricking your immune system to build your own antibodies, and that takes time. And your immune system is actively involved in that process, okay? So all your IGs, they're passive vaccinations. All your toxoids, the longer form ones that require you to build your own antibodies, those are active because you're actively involved in why you get a flu shot in late summer, early fall, because it takes a couple months for it to build up in your body, the antibodies. That is active vaccination. You're actively involved in that, okay? So that's your distinguishment between those two terms there, active versus passive. All right, a lot of snake bites out there. Fortunately, not many people die from them. Not every snake bite has a lethal dose of poison or toxin in it. Of course, some snakes are non-venomous, so actually only very few people get complications from these. And even if they did have, poison or toxin injected into them, is it always enough to cause a full, mortality or significant wound with it? Not always. Sometimes their poison glands are not full, and they'll get like a partial dose. We do have two large families that we worry about as far as poisonous goes. We've got the crotalids, which is also the vipers, and that's just the name for their family. Viperidae and crotalid being the same thing. And then we got the elapids, which are the coral snakes. Okay. Now, of the two, the pit vipers, the crotalids, are most likely to present first because their venom causes two problems. It causes first local tissue destruction. So as soon as they bite you with those fangs, those enzymes go to work and they start breaking down tissue, causing the swelling, the pressure, and possibly the compartment syndrome. It hurts right away, significantly. The secondary effect is the blood poisoning, the hemotoxin. So for pit vipers, we treat two things. We treat the local area, like compartment syndrome, and we also have to look at their bleeding or their clotting cascade factors, and is that being affected? Now, the coral snakes, these just have a neurotoxin, and the actual bite itself, it doesn't affect the extremity. I mean, it's still a puncture wound, but the concern is when this stuff is absorbed and they start getting those neuro symptoms like the numbness and tingling, which is paresthesias. And worst case scenario, with a large enough dose, they may actually get respiratory paralysis. Okay. And their onset can be delayed. So pit vipers, more likely to show up right after getting bitten. Coral snakes may not show up until several hours later. So these two large families, there's a couple things we can tell with them. They're not going to show you pictures of snakes on the exam, because that would probably scare half the people right out of the exam center, right? But your pit viper family, they've got this triangular shaped head, and they've got this elliptical shaped pupil. So it's not round, it's like a stretched oval. And they've got this heat sensing pit. They really don't use their eyeball for anything. It's very basic, it's very, not old, but very non-functional. This is like infrared. This is what they actually quote unquote see with, okay? This heat sensing, or think of it as an infrared sensor. So those are three ways to tell it's a pit viper. And then the coral snake, we look at the colors on the bands there. And we've got a couple different memory tools to remember. I actually looked up one time, there's like 13 of them. But one of the easy ones is red and yellow can kill a fellow. So anytime there's a red stripe, there's also a yellow stripe right next to it. So red and yellow can kill a fellow. Over here, red and black are okay for Jack, or red and black venom lac. Everywhere there's a red one, it's adjacent to a black one. Now, I know at the moment of truth, when you see one of these, you know, it just scares everybody and you can't remember the rhyme. But again, they're not going to show you, they might ask you about the colors though. So I would highlight that. It's kind of easy to remember it for test purposes, but in real life, it might scare the bejesus out of you. So the coral snake is the one on the left there, because the red and yellow are bad for a fellow when you see that. All right, so we want to assess this wound. Any symptoms they're having. Again, the pit vipers, they have fangs. And so we got two large puncture wounds to deal with. We still got to clean them. The coral snake have teeth. So we're still going to clean that. These are still small puncture wounds. Okay. The lab test, this would be for the pit viper because it causes that hemotoxin, that blood poison. So we're going to start looking at clotting issues. All right. So the PT, the INR, fibrin degradation or fibrin split products. That sounds like it has something to do with clotting, right? And then maybe the urine, myoglobin or CPKs as well, or CKs, because the compartment syndrome risk. So really for a coral snake, we don't need any lab tests because it doesn't cause lab abnormalities. For the pit vipers, we got to look at basically the clotting issues or the consequences of possible compartment syndrome and that muscle tissue breakdown. We're going to just keep that extremity still. We're not going to put any tourniquets on it. We're not going to suck any poison out. Just keep it still. We want to reduce the use of the area. All right. And we're going to do reassessments. You're going to be measuring to see the swelling. Is it progressing or not? Comparing one side to the other. Right. The provider in consult with a snake expert or like a poison control center or something, they'll decide if they need the antivenom or not. Antivenom is only for the pit vipers, okay? Only for the crotalids, only for that family. We don't have antivenom for coral snakes. What do we have for coral snakes? What's the worst case scenario? Respiratory paralysis. We've got something for that. It's a number 8 at 21 centimeters. We can deal with that, all right? So antivenom, brand name is Crofab, is for the pit vipers. And the dose they order will depend upon the degree of how much envenomation they got, or the provider guesses. Usually it's a minimum of 4 vials, 4 bottles that you have to reconstitute. Your bees and wasps and such. So not only a puncture wound, possible infection also because it's a break in the skin, but also we have here the risk for allergic reactions. A lot of people have allergies to this family. Remember, this was the Hymenoptera family for the most part. And if they're allergic to one, they're probably allergic to other ones. Let's see, urticaria, those are the hives again with the allergic reaction. If a person has a history of asthma and they come with a bee sting, watch them closely. Typically, asthmatics have a higher propensity for other allergies and anaphylactic reactions, because actually asthma is considered an allergy of the airways in a sense, and the same intrinsic issues they have that put them at risk for asthma can also put them at risk for insect bites to be allergic to them or stings. So just watch those ones closer. If the stinger's still in, we want to scrape it. We don't want to pluck it because we might break it off, or we might squeeze more of the venom or the toxin into that area. So scraping motion is recommended. And you've got a whole list of medicines we're going to use here. We've talked about this a little bit under, that was last night's lecture, but similar slide here. You don't need to know specific dosages, specific ones, but can you look at this list and appreciate that all of these have a possible use with allergic reactions, depending on the degree, okay? Can they give you a list of 20 medicines and you pick 3 or 4 that are used for allergic reaction? That's all you gotta do is name recognition. Now, if they have anaphylaxis, they might be carrying an EpiPen with them. They may have used it. One of our responsibilities is to make sure it gets refilled for them so they have it for the next time. And as far as other prevention, to prevent some of these insect exposures is insect repellent with the active ingredient being DEET. D-E-E-T is the most effective component of insect repellents. And that's just 4 letters. It's a long chemical name. They just abbreviated D-E-E-T. Carpal tunnel syndrome. So this is anything that increases the pressure in this small compartment, which is made by the carpal ligament holding your wrist bones together. All right. So things like fluid retention, repetitive use, repetitive micro trauma, things like that. That pressure goes up and it starts to shut down this nerve, and they start to get these symptoms of either the numbness and tingling like paresthesias, they can get the sharp nerve pains, and they could eventually progress to outright numbness, okay? But the underlying problem, this is what we treat, is this buildup of pressure in here. Now, easy diagnosis to make at the bedside. It just requires a physical exam, and we've got 2 things we can do. So Tennell's sign, you're going to take that wrist and put it in the position of extension. All right, the word extension has a T in it, and Tennell's sign has a T also. All right, and extension makes it better. The word better has 2 T's. All right, extending this compartment opens it up and eases the pressure. Now, once we do that and hold it in extension, we're going to tap on that wrist very forcibly, and that's going to start it right up again. The percussion is causing that nerve to be overstimulated now. So you fix the position, but now you're stimulating that nerve. All right, Tennell's, tapping, extension makes it better. Phalen's is all the opposite. Phalen's sounds like a letter F, and you're going to flex the hand. You're actually, you could even say flexing the phalanges. So those letter F's kind of sound familiar. And this flexion increases the pressure and makes it worse. So to do Phalen's sign, they're going to hold that wrist at like 90 degrees. You're going to hold it for about a minute. And that pressure you just increased is going to exacerbate it. It's going to bring the symptoms on. So Tennell's, T, tapping makes it better. Extension. Phalen's, you're flexing it. You're forcing it to be worse. Now, if there should not be trauma with this, this is usually gradual onset, repetitive motions over time. So I don't need x-rays necessarily unless there's some blunt trauma, but carpal tunnel is a chronic condition that builds up. Nerve conduction studies on the outside, like in a clinic, especially if it's really recurrent or hard to treat. All we're gonna do is a physical exam, listen to the story, and put them in a wrist splint, all right? And that wrist splint needs to be in that position that makes it better. What position was that? That was the extension, all right? So it needs to be cocked up or some degree of elevation there to open that compartment up for it to be effective. Compartment syndrome. So this is an end result of anything that causes that pressure in this closed space to go up. So our common things are crush injuries, burns. Remember the pit vipers with that tissue swelling and edema, that can cause a compartment syndrome. Once we get compartment syndrome, it's the same across the board what we're going to do for it, because now the underlying problem is too much pressure in that area. How we got there is different, but once we get there, we treat it all the same. Okay, and we can cause it medically even. If we put those splints on too tight, we're compressing that compartment. If I put a cast on before the swelling's gone, I can compress that compartment too much. Now, fortunately, we're not using the mask trousers or the PASG hardly anymore at all, but those could cause it too, because basically what you're doing is putting those on and you're shunting the blood from the extremities to the core. You're kind of causing compartment syndrome in the lower extremities. But we just don't do that much anymore, so it's not usually an issue that we're going to see. As this pressure starts to go up in this closed space, all right, it's going to shut down the lowest circulation to the highest circulation as the pressure goes up. So the first thing is the lymph vessels are going to get obstructed, and it's going to get kind of puffy below the area of the injury. Pressure goes up more, now you get the venous system obstructed, and when the venous system is obstructed, you can't get the blood out of the area. So again, the blood's more and more accumulating, it's getting bigger and bigger. Now we got, the next step is to compress the arteries, and now we're going to lose a pulse. Now, even though losing a pulse is very important, still we can have more pressure accumulate in there and shut down the motor and sensory nerves. So that's the order of progression from lowest system to highest pressure system: lymph, veins, artery, and then motor and sensory nerves. So a true anesthesia, when they can't even feel the extremity, that's like the full on. They can't move it, it's paralyzed, okay? You already lost blood flow before then, but just realize losing that pulse needs to be a really red flag that there's more pressure that can still accumulate here. So because of the reasons that lead to this, those crush injuries, things like that, we want to look for possible rhabdo, markers of muscle breakdown, maybe look at potassium from these damaged tissues. So our lab tests don't tell us about compartment syndrome. They tell us some of the other associated things by nature of how they got this. Probably crush injuries, your most common one. All right. To actually measure the compartment, we're going to use a striker needle and actually measure the number. Okay. It's technically called a compartment pressure needle. Your normal pressure should never go above 20. 10 is like your day-to-day. It's allowed to elevate some up to 20, but above 20, the diagnosis is there. Okay, and that's the amount of pressure that's resisting the oxygen going across to the tissues and oxygenating it. Now, we do not do an emergency fasciotomy at 21. Okay, not all your perfusion is shut down at 21, but at 21, you have less than 20. At 25, you have less than 22. Somewhere around 30 or 40 is where they make the call, do we need to do an emergency fasciotomy and rapidly open up this extremity to allow that pressure to reduce and perfuse the tissues. Okay, so yes, the diagnosis exists at 21 millimeters of mercury, but we don't even consider doing it until it's somewhere around 30 or 40, because you're talking about doing a hasty, non-prepped, under less than ideal circumstances, surgical incision into an extremity that you've not even dealt with the wounds underneath it yet. So it's truly a limb salvaging procedure. So an example of doing a fasciotomy on a lower extremity. Now they have to put some retention sutures in there, not to close it, but they're holding it from splitting open even further, basically, because you're going to you want this to be open, all right? And of course, you're going to have to do some wound revisions to this, deal with the broken bones that are under there, etc. There's still a lot of work to go here. Your bruises and such, these are pretty straightforward. We see a lot of these with our other concurrent injuries. Basic care for these, ice, limitation of range of motion, supportive care, basically. But we want to keep in mind, you know, could this person have a bleeding issue? Could it be an undiagnosed like hemophiliac or ITP patient? not suggesting that we're going to order lab tests and all these. And most of these patients already know they have that condition. But let's say just from a minor trip or a minor bruise or contusion, this patient's entire leg is now ecchymotic. You know, that might clue me into something else. Or what if when I look at them, I'm seeing other areas that have ecchymosis that aren't part of the injury? That might clue me into that also. Or what meds are you on? You know, if they're on Coumadin, I need to look at that INR, because what if their INR is 3? That bruise ain't going away anytime soon, right? So I'm gonna look at the bigger picture, but basic bruises and such, they're basic home first aid care, ice, compression, a lot of that rice stuff that we do for other ortho stuff as well. Okay. I'm going to have us take a break here for about 10 minutes. We're going to finish this up in just a little bit, but if we try and do it all at once, the learning curve goes off and you start to zone out and stuff. So we'll take a quick refreshment break and then come back and we'll finish this directly up. Before you go to break, let's see if you guys have been in a session before. First, let me give you a time so no one to come back, because some of you guys are like, I've already seen this. Hang on. So I've got 20 after, we'll come back at 30 after. If you already sat in one of these before, you know about the evaluate. Well, I'm gonna show it anyways. You know where the evaluation is. It's on the website. You can go there and pull it up and do that at any time. For those that have not seen this, I'm gonna walk you through it. So that way, as soon as we're done this afternoon, you can just head out and you do this evaluation at your leisure. So you'll go to my website and I'm gonna type it in here for you. We'll type the easy version, which is just passthecen.com. Now that does redirect you to the long word here, but passthecen.com is easy to remember. Over here under other stuff, on this tab, you'll see Flex Session 3 Course Eval, and we're in number 3 today. You'll click on this, and it's going to confirm with you that you sat in on the ENT, the OB, and the ortho and wounds, and you're going to hit start. It's going to take you to a Google form, and you're going to type in the email address that you want this certificate to go to, because this will be automatically generated. And you're going to type in today's date. I'm going to let you guys do that. And I use this open because I keep this up. If someone takes this session, you know, a new person takes it next week, they'll type in the dates they're on it there, that they took it then. So type in today's date, which is, what is today, the 14th or 15th? I forgot already. Your name as you would like it to appear. All right, Nancy Super Nurse, if you want to do that. This is the hours. So if you attended the whole thing, you can claim 4.5 hours. You just type that in here. It's an on your honor system. I don't track these. I don't chase you down. You know, if you legitimately took a nap for an hour during section. But anyways, this will print on your certificate. So whatever you type, you get, but you can't type more than 4.5. A couple scales here to state, you know, was it worth your while, et cetera? Was it effective? I'm going to point out this part here. So these are the 3 sections we did today. The first time you answer these, you're asking yourself, before you sat in this class, your confidence and knowledge of each section was, and just self-rate yourself, okay? And then the next time you do it here, it's going to be after attending the course, my confidence and knowledge is now, and then rate yourself again. And hopefully you'll rate yourself at least somewhat higher, hopefully no worse than you sat here. Because this is one of the metrics I had to submit to the ENA, that when I designed and got accredited by the ENA for this program, they said, what are you going to measure? Okay, what objective? Now, it gets submitted anonymously, but I still need to show them that hopefully the people are still marking that at least they're coming out better than they were before they took the class. In other words, proving it was actually beneficial. The mandatory one is here. It's mandatory, it's got a little asterisk here, is tell me one thing you learned new or different after sitting here today. So think of something you didn't know before you got here. It could be something, just a point of minutia. It could be compartment pressure that should stay below 20. It could be something along, whatever you want. I just challenge you to put at least one thing. I get enjoyment seeing frequent things people mention that they weren't aware of before they took this. And then you hit submit, and it'll give you a confirmation page and say it's been submitted. And depending upon your email program, within about 10 to 30 minutes, you'll actually get an email. It's an automated one. The certificate will be attached as a PDF with all the info you put on there, your name, the date, and the hours, and the course provider numbers and all that. It'll be on there, and you can print that off or save that. Okay, so it's all automated. So quickly again, you would just go to my main page and it's under other stuff and you're doing session 3 today. So you click that. All right. Okay. Next 10 minutes is y'all's. We'll come back. We'll finish this up. And as soon as we're done, we're done. So we've covered that. If there's any questions about anything you need to ask, I will look for them. All right. Our next topic is costochondritis. And this is an inflammatory chest wall pain, usually the ribs or the muscles or the cartilage. So steroids might be part of this treatment, or non-steroidals, because it's inflammatory. But to diagnose this, we have to rule out the things that it could be. So when you think of all the possible causes for chest pain, we got to do some rule outs. We got to make sure it's not an acute MI. We got to make sure it's not a pneumothorax. We got to make sure it's not pneumonia if they're having like fevers and chills. So to diagnose costochondritis, we're going to do some tests. As far as what tests we're going to do, it'll be dependent upon the patient and presentation. So if the patient's like, 55 years old, clutching, gripping chest pain down their neck and jaw, I'm going to get an EKG and some enzymes to rule out an acute MI. And if that's normal and though they're not elevated, they're not positive, then I might say costochondritis. Maybe a chest x-ray to rule out pneumonia, things like that. So we got to consider what's appropriate for the patient. We're not doing everything for every patient. It'll be history and risk factor dependent what we're going to do. And the treatment for this is just anti-inflammatories, maybe muscle relaxers, maybe some pain medicines for some of these people. Your sprains and strains, they're pretty straightforward. You sprain a ligament, you strain a muscle. We're going to treat them basically both the same with our RICE, our rest, ice, compression, elevation. Now, there are some evidence tools we can use to diagnose, well, not diagnose, but to decide who needs x-rays and who doesn't. In the real world where we all work, we x-ray everything, right? But if you think about it, we want to look for the person who has a clear indication there may be a fracture here. So for the exam, if they want you to x-ray it, they're going to tell you there's some bony deformity, there's some crepitus, there's some range of motion issues. These Ottawa rules, you do not need to know them for the test. I'm just showing you these are some of the tools as providers we look at if we have time to do it. We're not having to x-ray everybody. Like in a clinic setting that we're going to look at and see do they really need an x-ray or not. Okay. The Achilles rupture, this is a classic presentation. You can rupture any tendon. This is the most common tendon rupture that shows up. All right. And with any tendon rupture, they're going to use phrases like, it feels like I got suddenly hit by something, or like a baseball bat, or it's that sudden tearing of the tendon that causes the pain. The tendons are avascular. They hurt real bad when they tear, and they're just kind of sore like a bad bruise. The Achilles would be the most common one. One way you can tell this on bedside exam is if you palpate their calf muscle, you'll notice their calf muscle is one big knot or ball behind their leg because the Achilles is ruptured. It's no longer holding it down attached to the heel bone there. So rest, ice, compression, elevation. As far as how long are they off these extremities, how long are they non-weight, that depends on the provider, depends on the injury. So that's not really going to be, it's not fair to say, does a sprained ankle do no weight bearing for 3 days, 5 days, 7? That depends on the provider and how they're choosing to manage that. Just know they're going home the first day and not putting weight on it, right? I think we all can agree on that. Probably the earliest you see some providers, if they do full non-weight bearing limitations, the earliest you'll agree, I think you all agree, the earliest they let them start putting weight on it is usually the next day or 24 hours later. So usually like a 12 to 24 hour period of no weight bearing. Crutches and stairs, ideally the patient's going to use a handrail. That's more sturdy than any crutches that are made. But if they don't have a handrail and they have to go upstairs and they got crutches, it's a little memory tool. You go up with the good leg and you go down with the bad, meaning going up the stairs, the uninjured leg puts the full weight and pushes you up with the good. Going down the stairs, the bad leg and the crutches go first, and basically your body weight is on the crutches, and then your good leg comes down behind it. So up with the good, down with the bad. You see there in the notes, I've discussed some of the different descriptors as far as the fractures. You do not need to memorize that. That's just part of the conversation when we describe fractures, like we're calling ortho for a consult or whatever. We're going to use those characteristics. You know, is it displaced or non-displaced, open or closed, and so on. These aren't for the exam. These are just other learning points for you. So you don't need to highlight these and work on memorizing those. You don't. But when we see these fractures, we want to, like the amputation, don't tunnel vision in on just the fracture, because we still need to do our ABCs also. We generally, most fractures get assessed during the secondary survey after we've done the primary, the ABCs. We come back and reassess these fractures. And we're going to splint it in the position that's found. We're not going to try and reduce these things. That's a provider call. We need some x-rays first anyways. And of course, they're going to need some pain medicines. Sometimes, especially you can plan ahead. Most people know, like those forearm fractures, those distal radius fractures, there's probably going to be conscious sedation involved or procedural sedation. Those are probably the most common ones we do for that. We'll get to the dislocations here in just a minute. Now, if it's an open fracture, we need to protect this from contamination. So we're definitely not going probing or trying to debride or whatever. We're just going to cover this, protect it. If I do any irrigation, this is the one time I want to use saline only. Saline only, because all those other things like the betadine, the Physahex and all that, you have to irrigate those also. And there's the chance you may not be able to irrigate that completely out of there. Sometimes the open fracture is pretty obvious, like the previous picture. Sometimes it's not. So I'm still going to treat that external wound. Even before I get the x-ray, I'm going to treat it like it is an open fracture until I know otherwise. In this case, just that small wound there was made from that complete fracture on the right-hand side there. Now, I meant to tell you the paragraph above there, the mask trousers, the PASG, you can cross those off. Those are not in the exam. They're not currently a standard of practice anymore. And again, as I'm doing my edits, the next version that comes out will not even have that in there. So you can just cross that off. All right, so irrigate only with saline, and then possible tetanus shots, antibiotics. This guy's got another trunk monkey that may save his life.
On my way into work, I spilled hot coffee on my lap, and I lost control of my car.
Shock advised. Stand clear.
No. For the most part, I'm glad that I bought a car with the trunk monkey.
The Trunk Monkey, a life-saving idea you'll only find at Suburban Auto Group.
So a little extra feature there on some cars might save your life one day. Our traction splint. So this is a device we're going to use for our mid-femur fracture. And the purpose of it, or the indication, is to stabilize that area. All the other things about less pain, less spasm, all that, those are all great. But the underlying principle of this is to stabilize that area to prevent no further damage. Because one of the concerns of the mid-femur fracture is that disrupted bone and the amount of bleeding that can happen in there. If I pull it tight and stabilize it, that may actually help to tamponade it and slow down the bleeding and prevent it from more happening if those bony ends were to move around. Now, the contraindications of this is I do not want to apply it if there's a hip, an ankle, or a knee fracture. Okay, because when you look at the device, there, look where the traction is being placed. It's being pulled from the hip to the ankle, and the reason the knee is a contraindication, because if you have a tibial plateau fracture, some of those supporting ligaments and tissues are disrupted, and you may be pulling down here, and it's not actually even pulling on the femur because the knee's gone. So contraindication is hip, ankle, or knee fracture. Okay, and the placement, both devices work the same. They're both placed the same way. This is your Sager device. I'm sorry, and this is your hair device. This one just folds up smaller to occupy a smaller space, like in an ambulance or a helicopter. Both of them are placed by a minimum of 2 people. One person holds the foot, and they pull lengthwise, holding manual traction. The other person places the device under them and straps it on, and then they come down to the end of it here, and they both got some device like a little ratchet or a roller, and they're going to tighten this down, and they're applying the mechanical traction. As far as the answer, how much traction do you put on it, how much force? Mechanical needs to be more than manual. So basically the person holding the foot feels like the device is now taking up more of the tension, and basically the foot is coming out of their hand because the mechanical device is taking more tension than the manual traction they're holding. We're not going to worry about poundages or percentages. When we do teach EMS guys, when I worked at the junior college, we do teach paramedics on this device. They can actually calculate the body weight and apply a certain percentage of traction. We're not going to worry about that. The minimum is the mechanical always has to be more than manual. And then we're going to reassess that because it is a splint. You can dislocate any joint. There's common ones that show up in the ER, and probably the most common one that requires an ER visit is a shoulder. Fingers actually happen quite a bit. A lot of people will self-reduce their own fingers. I've seen it, I've done it myself. Shoulder is the most common one, so they are the ones that will be on the exam. Most of the shoulder dislocations are anterior, which is showing in the picture how it comes forward and downwards, and it can be just from being in the wrong place at the wrong time. Anterior dislocations don't require a lot of force. I've heard people just reaching overhead and it popped out, okay? The talking point for this is the posterior, because this is very rare. This requires a lot of force and a lot of trauma for that humeral head to actually come around and behind the capsule area. There's going to be some joint damage. There's going to be some torn tissues with this a lot of times. Because the amount of force that's involved, we have to consider, could this be the first presentation for a new seizure patient? The amount of thrashing about with that grand mal type seizure. And true to form, I've only seen 2 of these, by the way. The 2 that I've called ortho for, that was their first question to me. They said, is this an epilepsy patient or do they have a seizure? I'm like, oh, okay, we're thinking the same things here. This is a high force energy, a high force injury pattern. All right, so posteriors, very infrequent. Think what other forces could be going on there. The radial head will be a common one with kids. And this is at the elbow. And so the radial head of the radial bone. And this is your most common mechanism. Kids not in a lot of distress with this. I mean, it's uncomfortable when it happens, but as long as you let them, and they're probably already doing this, holding their arm against them, up against their chest, they're pretty much happy, all right? The parent may not even know this is what's happened. They may just say, hey, the child's not playing with his toy cars or whatever. He's not, doing color crayons with his dominant side there like he normally does. What's wrong with him? If you start to examine it, the kid will let you know it's uncomfortable. Send him off to x-ray, and sometimes it gets fixed at x-ray, because to get your elbow x-ray, they have to bring the arm off the chest, they have to rotate the wrist a little bit, and then put it at full 90 degrees. And sometimes that's just enough to get it to slip back into place there. The bursitis. So this is part of your joint, but it's extra articular. It's actually outside the joint, and it's a little separate cushion. Basically, it protects some of our bony prominences from friction and trauma like that. So it's still the same joint fluid. It's still synovial fluid, but it's just in a different compartment or a different cavity, if you will. Okay, so it's the same fluid that would be inside the joint here. So repetitive use, stress, trauma. This is a very dramatic picture I've given you, but it drives home the couple teaching points with ways to recognize it. Because the bursa is so superficial or extra articular, when it swells, it's very definite where the swelling starts and stops. It's only swelling through a couple layers of tissue. All right. Now, I've never seen one this bad, but I like this picture because it can definitely show where it starts and stops here. All right. One of our concerns with this, while it's almost always inflammatory, is could it be infectious? Okay. And why do we worry about that? Well, 1, because they need antibiotics. 2, because the treatment for a lot of these, the best treatment is to aspirate and get that fluid out, make the patient happy, make them feel better. Sometimes that's all they need. However, because it could be infected, I don't want to stick needles into any infected tissue or joint space, because there's a potential, if I were to aspirate this, I could go too far and inoculate the deeper tissues some of the infection. So a lot of times before you see us go in there and aspirate these, we'll be ordering some lab tests. We're trying to rule out infection. I should have a normal CBC. We're trying to rule in inflammation. So things like our SED rates or our CRPs are going to elevate. Okay, and for that, you can use, I know a lot of ortho guys use both of these, but either one measures inflammation. Okay? So I'm trying to feel really good. This is just inflammatory, and then I can go in there and aspirate it. Why would I need a chemistry panel? Because sometimes the treatment for these is anti-inflammatories or steroids, and I want to be safe that I don't have someone who may have like new onset renal insufficiency or chronic kidney disease, because those drugs could make their kidney disease worse. So I'm looking to see normal renal functions on their chemistry panel. But at a minimum, I need the CBC and the SED rate to rule out infection and to rule in inflammation. The tendons, so any tendon can get inflamed and cause a problem and get tendonitis. The most common one will be the elbow. And of the two in the elbow, it's going to be the lateral tendon. Okay, that's the one. So I'm going to show you the picture of the kid, but the tendon we're talking about is the one that attaches from the radial head to the lower humerus. That's your lateral ligament. That one is used when you rotate your palm up and down. That's why it's called tennis elbow, because when you're playing tennis, you try and hit the ball and put a spin on it, and that requires rotating the wrist, rotating the elbow. So that's one question you can help to assess the patient to figure out if you're dealing with this lateral tendonitis or this tennis elbow, is what movement makes it worse, what makes it less. And if you ask them to rotate their wrist, they're going to tell you that's very painful, because that's that tendon having to do that work there. All right. It could be warm, swollen, or inflamed. They're going to be very tender right over that tendon line where that tendon lies. Okay, so the whole elbow may be sore, but if you press right along that tendon, they'll tell you, oh, that's it exactly right there. So the treatment for this is to put some type of brace or splint on there. And I don't mean a splint like a rigid splint, but something to stabilize or strengthen that area. I don't want to immobilize it. What I want to do is put something to give some extra strength there. So ideally, it's usually a strap like this, and it goes right over that area, and you tighten it down. And what it's doing is it's giving some extra support to that angry, irritated, overused tendon. So when they do the movement of the rotation, it's less painful. Okay. And sometimes that's all they need. Sometimes they need some anti-inflammatories, maybe some pain medicines, but usually just the brace alone makes a big difference in their life and increases their or decreases their symptoms. Our gout patient, so there's really no emergency with chronic gout. The acute gout has an emergency. Not that they're going to die from it, but we need to separate it out versus infection versus gout, because the treatment's going to be different. Okay. Chronic gout, that's a whole different story. That's not the same presentation. The pathology behind gout is this uric acid. It precipitates, or it comes out of the fluid and forms crystals that get trapped in these small joint spaces. Things that can aggravate or exacerbate a gout attack or bring it on. I don't think it's on here, but dehydration, yeah, because that's under education. Dehydration is a common trigger for this. Also, purine foods. What are purine foods? There's a whole list, it's huge, all right? Some generalizations about purines. Organ meats, like liver, gizzards, those kind of things. Those organ meats have a higher concentration of purines. Dark aged wines have more purines in them. Those older moldy kind of cheeses, yeah, cheese has mold in it, but I'm talking like the blue cheese, the ones where that's actually part of the product, is to have that high mold concentration. Sardines are another one. So these are just some common ones. Your discharge sheets probably have some things printed on them when you discharge a gout patient for them to reduce in their diet. But if you were to Google it, there's a whole long list. If they're on hydrochlorothiazide, they probably need to stop that. That has been proven. The HCTZ for their blood pressure can precipitate that also. I've done that a couple times in my career where I've had a new gout patient and they're on that, and I told them, hey, we're going to DC this and we're going to find you a different blood pressure medicine because it can cause a trigger for this. So it tends to affect the small distal joints first because that's more likely where these gout crystals will get trapped. So toes, ankles, feet, it can happen in any joint, but it's more likely to be the small ones first. So it's not fair on the exam for them to say, guy presents with, sudden onset hip pain. That's not the likely presentation. It's going to be a toe or a foot, and it's going to be so painful, they probably will not even let you examine it. They probably are not even wearing a shoe or a sock on that foot because it's so exquisitely sensitive. And we're going to clue in on the time of onset, okay? That's one way we can tell gout versus other things. Is pretty sudden. Again, the hours, not the 5 days. They probably even went to bed normal and woke up in the middle of the night and boom, it was there. It had been swelling while they were sleeping so soundly. Now, this isn't ischemic pain. This is just truly pain due to those crystals accumulating there. But we're looking for keywords like sudden, rapid, overnight kind of thing. If you get only one tube of blood or one drop of blood from your patient, you're going to run a uric acid. That will be your most specific, useful enzyme to look at, or not really an enzyme, marker, shall I say. Should not be infected, so CBC should be normal. If you do a SED rate or CRP, it will be inflamed because this is part of an inflammatory response to the uric acid. But uric acid is your one you need to know for the test. So teaching points, again, encourage them to stay well hydrated. Obesity is also associated with some gout patients. Anti-inflammatories, remember, we see the worst of the worst. There's a lot of people, their gout is managed just fine on routine use of like diclofenac, double dose of Aleve, things like that. Colchicine is a specific anti-gout medicine. What colchicine does is it helps to reabsorb the uric acid. All right, so that's a specific, it's not anti-inflammatory, it's not a pain medicine, it's an anti-gout medicine. Colchicine is one of the few that's out there. Brand name is Colchris. I heard it's actually brand only now and getting pretty expensive. I know there used to be a generic one out there, but I've had a conversation with a few patients who said, yeah, they tried to look at it or their doctor tried to give it to them, but it was way too expensive. I don't know, but it is an anti-gout medicine. Your joint effusion. So this is inside the joint now. So the bursa was outside, this is inside, and the knee will be the most common presentation for this. Almost always, again, inflammatory, but we always have our radar open or our little spidey senses. Could this be an infected joint, which would be treated differently? Now, these rare joint infections like a septic arthritis or gonococcal or even a syphilitic arthritis, those aren't going to be on the exam. The most typical one is inflammatory, and then if it is infected, it would be your usual staph and strep germs, all right? Because for these other atypical ones, they have to have some high-risk behaviors. And let's face it, of all the knee pains that come to your ER, most of them are just your average 50-year-old, 60-year-old with some chronic recurrent arthritis, and it's flared up again. So we're going to look at the normal knee and notice, okay, that looks pretty normal. And then over here, you see all this swelling going on. Now, it's not as distinct as the bursitis because this swelling is coming from the deeper tissues down below. So it's having to swell through more layers of tissue and it looks more subtle, but you can still tell that there's a difference between these two. Okay. One of the things we can do to examine it is we can put our fingers on either side of the patella, the patellar tendons here, and you can push back and forth and feel this fluctuance or this fluid kind of moving back and forth. It's fluctuant. It's mushy. All right. Ballottement means to now take your fingers and actually tap or push on one side and feel it bounce, the fluid wave bounce to the other side. Ballottement means to bounce or to move back and forth. So that's one way we can tell this fluid is actually extending all the way through this joint capsule. It's not just the bursa, but it's actually under the tissue extending all the way out. Now, Again, this is almost always inflammatory. So my CBC should be normal, my sed rate, my CRP going up. Maybe if it was sudden onset, I might get the uric acid. Say, could this be like a gout mimic? Maybe, but at a minimum, CBC and the 2 inflammatory tests. The other ones would be on a case by case. If the guy comes in, he's got multiple IV tract marks, he's one of your regulars, and you know he shoots drugs all the time. Yeah, maybe I need to look at hepatitis as far as risk for other diseases, and this is maybe an infected effusion. But at the end of the day, it's going to come back inflammatory, and best treatment is to aspirate it. So you might see the physician go in with a big needle, pull this inflammatory fluid out, and if they do, a lot of patients, they get a great degree of relief just by doing that. And then, of course, medicines at home, at least something for inflammation, because that's what the root cause of almost all of these is. Maybe some steroids. Your osteo is your bone infection. Now, it starts in the bone, but then it leads out to the soft tissue eventually, and can become more of a systemic infection also. So whenever someone has osteo, we have to go backwards and think, well, how did you get this? Because you should not get osteo unless you've had some damage or defect to the bone, because your bone actually has a protective surface, a protective membrane over it, all right? And the sources are either going to be from the outside world, so exogenous, or the inside of the person, hematogenous. So your most common one will be from the outside. Those, maybe they had a broken lower leg, they went home with the external fixator on, and those pins of the fixator go right into the bone and could possibly carry germs into the bone if they're not doing good pin care at home. So that's your most common one. And it can even show up weeks or months after the fixator has been removed, because bone tissue grows very slow. So it doesn't show up right away. And it starts in the bone tissue, the bone matrix, and works eventually out to the soft tissues, also causing that bony destruction and just that liquefaction, necrosis of the bone, and then just that tissue turning into pus, basically. And as the bone gets damaged, you see it actually basically turns just like this mushy stuff. Now, this is a very advanced case here. Now, what's the fix for this? Is we're going to have to amputate up to the joint here to make sure they get it all, because you don't know where exactly in this foot bone it's still active or not. So the best case is just to take it at the joint line there. Now, some patients don't show up until it presents like this, where it's finally come through the skin. And because this isn't always a serious, extremely painful thing when they have osteo. It could just be a dull, achy thing. And sometimes patients are like, oh, I don't want to go sit at the hospital for 8 hours. I know you got to wait forever. I'll go on to work. But when it breaks through the skin like this, we've got a problem. This absolutely needs surgery. This absolutely needs long-term antibiotics. Now, the bone scan would be the definitive gold standard test for this. We don't have to do that in the ER. A lot of times our x-rays and CTs will show up for the osteo, but at some point ortho needs to do a bone scan, because they need to see how far along is the bone metabolically active. Then that helps them stage and decide what surgical technique they're going to use. How much bone do they have to remove? Because it may extend beyond the joint line. The CT is not going to tell us that. The bone scan looks at the metabolic active areas that are currently fighting the infection. All right, so surgery is in their near future. Now, if they're stable, and it's not this bad, they might go home without patient follow-up after loading some antibiotics. It just depends how sick they are or how extensive it is, if they need to come in or not, because the bone scan can be done outpatient if they're very well and very walkie-talkie, and we've made some adequate follow-up arrangements for them. Puncture wounds, we've talked some about this under the insect bites, some about puncture wounds under the snake bites. I'm going to talk about one that's a little bit different, which is when you step on something through your shoe. Okay, it's still a puncture wound, it's still a high risk for infection, but if you step on something like a nail and it goes through your sneaker, as it goes through your sneaker, it can pick up the rubber, the foam, the fibers, and deposit them into the wound. And those substances can grow Pseudomonas. Pseudomonas is treated completely differently. Your normal antibiotics you use for infections like Keflex, Bactrim, the doxycycline, others, Those do nothing for Pseudomonas. Pseudomonas requires quinolones. And at the same token, quinolones do nothing for the staph and strep germs that are there usually. Okay, so it's a whole different treatment. How do we prevent this from becoming Pseudomonas? If you step on something through a shoe, the best care is the provider is going to numb that up, make a small incision into the wound, and irrigate it out completely, trying to get any even microscopic particles out of there so they don't cause that Pseudomonas, which is basically a nasty infection anyways. So that's the only time we do it a little bit differently. All other puncture wounds, we can just do external wound care, put them on antibiotics, but this will be the time I need to irrigate it out from the inside. If there's a foreign body present, if it's organic, like wood or like a plant, and I've seen this in the exam a couple times, it was referred to like as a big, large rose thorn. You know, someone's out gardening, got a big rose thorn stuck in their thumb or whatever, or even like a splinter. Don't start soaking it until you've removed it, because those wooden organic things are going to break down to mush, and what could have just been a simple removal now has to be a true IND to get all that stuff out. All right. If you do not give anybody else a wound recheck recommendation or a follow-up, give the puncture wound a wound recheck referral, because these are the highest risk for infection. You know, ideally, everybody would get a wound check on day 2 or day 3. On day 2 or day 3, at least do it for the puncture wounds. So that makes for a good exam question, saying, of all these people, which one needs to go to the wound clinic or needs to have their primary doctor see it? You're going to say the puncture wound. Your penetrating injuries, we think about gunshot wounds and such. Commonly, there's not any specific questions about things like, you know, the physics of this, the cavitation, the yaw, the shock blasting. That gunshot wounds, you think about forensics. You know, you got your chain of custody, you got to bag the patient's clothing. You're going to cut around the bullet holes, not through them. Try and protect that evidence, because these are usually violent crimes. Even the ones that are potentially, oh, my gun accidentally went off. You know, how many times that story gone the other direction, right? So always err on the side of caution and think about forensics. The ones you don't think about a lot are these high pressure injection wounds. We don't see a lot of these. Now, this is a normal medical use of a substance under pressure, like a vaccination. So this is a biological agent that is supposed to be in the body. This does not cause a problem. The ones we worry about are things coming out of like factories and industrial settings, where these nozzles have these pressures, these tens of thousands, all right? And the things that are in these nozzles are not biological agents. Paint, thinner, solvents, okay? This stuff has to come out. Okay, it can't stay in there. It can cause tissue destruction too, in addition to the puncture wound or the penetration. This is out of ATLS, and the only take home you need here is the third step there. While the provider is spending all this time on this flow sheet trying to decide what to do with this, whatever the stuff was that got injected, you know, grease, oil, paint, whatever. Here's what it means to us in the ER. Okay, you show up from the local factory with a paint sprayer, injected some paint in your hand. Guess what? Well, the doctor's taking their time. I'm keeping the NPO, getting you in a gown. I got some consent forms coming. I'm gonna get an IV started. I'm gonna ask them about some antibiotics before surgery. And here's a phone, call your family, call your boss, you know, because you're going to OR, because that's the only way this stuff comes out is to go in there and open it up and scrape it out. And your most common body part affected will be hands, almost exclusively for these high pressure wounds. So we as ER people don't need to spend time spinning our wheels worrying about what it is. Clean the wound, it's a puncture wound, cover it, do all those other pre-operative things when you know someone's going to surgery at some point, because this is the only way it comes out. The general goal of doing laceration repair is to get the function back of that area, trying to minimize scar tissue. So your tissue has its elasticity, your tissue has its normal barrier protection against, you know, infections and all that, because your skin is basically your armor, if you will. And scar tissue does not function the way it normally should. So putting wounds together restores function. And by doing that correctly, we also get less risk for infection. Tissue has its normal elasticity, its stretchability, things like that. There's the 6 hours again about wounds start to change somewhere around 6 or 8 hours. So it doesn't mean we can't close a wound after 6 or 8 hours. Again, a provider that says that is being lazy. We may have to do it differently. We may need to take it to the OR and cut maybe a millimeter of tissue from around the edges, so we got fresh tissue to put back together. All right. Just the concept is know that tissue starts to change somewhere around 6 or 8 hours. We're talking about cleaning these wounds, got different wound care products. As far as wound closure, they're not going to ask you what's right or what's wrong, because technically you can close anything with anything you want. There's obviously some less ideal circumstances and some more ideal circumstances. For example, we staple scalps frequently, all right? Is there any law that says you cannot put staples in a face? No, there's not. Is it the ideal way to do a facial act? No. One, the staples are bigger, so they're going to leave a bigger puncture wound. From a cosmetic perspective. Two, you can't really get them to approximate as nicely as when you're using the nice, fine, thin suture material. It's going to leave a smaller hole, and you can actually adjust the tension. You know, the provider can adjust the tension as they pull it together to promote more function. Is there anything saying you can't put steri strips on a knuckle? Well, you sure can, but what do you know is going to happen when they bend that knuckle? They're going to pull off. So what if I do tape on a knuckle? They're going to go home with a finger splint also. So you can do these to anything. It's just some cases require extra steps. Some require a little modification. All right. Dermabond, you know, could do dermabond on a lot of different places. Probably not ideal to glue a laceration over the knee. That's probably going to pull right open. With the dermabond, can my patient avoid getting it wet for the next 24, 48 hours? Because if they go home and take a shower right away, you know, it's just break it down. It's not going to be as adherent or have the same tension or tensile strength to it. So they're not going to ask you, they might ask you in general, patient presents with a scalp laceration, your provider's probably going to ask for what to close it with. You're going to pick the staples. All right. Those kind of testing points. All right. That body part needs to be, just let it be for up to about 48 hours. Okay. You don't want to go home and do that first dressing change tonight. That tissue needs to start to granulate. Some of those early, those fibroblasts, all those other tissue precursors need to start getting there and setting up camp to start the underlying wound healing process. So somewhere around 24, 48 hours, they're going to change that dressing. Now, you don't want it on much longer than that because bacteria is going to start to grow there. Now, that being said, I'm sure you've seen patients who had surgery and that dressing's been left on for a week. Well, what's the difference? Surgery is done under sterile conditions. They do a significant surgical prep to that area. They do all these things to reduce the chance for infection. You know, all the sterile barriers and drapes and all that. In the ER, we are filthy. This is not something that they had time to do really a significant sterile prep to. So our wounds tend to have more bacteria build up sooner versus, oh, and also look how it's made. Wounds we deal with in the ER are usually made by other objects, like the lacerations from the MVC. A surgical wound is made under sterile conditions. You got a sterile scalpel cutting into the tissue. Okay, all the sterile instruments and sterile gloves. So that's why those ones can stay on later. Any cosmetic laceration, all right, so think head, face, neck. Even up to 6 months, we need to limit some sunlight exposure because even though the tissue's quote unquote healed, there's still some tissue turnover happening, and especially in the Caucasians, the fair-skinned people, that scar tissue can still form down the road. Okay, so, but you know, I'm not worried about their foot, their ankle, but if it's something on the cheek, I still want to advise them to put some sunblock on there, minimize their sun exposure to that area for up to about 6 months. Stitches removal times, you do not need to memorize this for the test, just the take-home principle, which is places that are closer to the heart or places that bleed more briskly, they're going to come out sooner because those are going to heal faster. Okay, so for the example might be 2 boys come in, they were playing on the trampoline, one had a laceration to his chin, one a laceration to the knee. Whose stitches come out first? You say the chin laceration. So don't focus on the times because Lord knows every time you go to work, they're telling you different time, you know, 2 different providers will tell you 2 different numbers for the same body part. our back pain. Yeah, you look at something right quick in the back here. So when you look at all the back pain that comes to the ER, of course, there's no drug seekers on the test. Most of it is going to be a non-issue. All right. Most of it is not going to be due to cancer, not due to spinal tumors, spinal abscesses. Most is going to be just due to overuse, deconditioning, somewhere in our 30 to 40 age range. Because it's somewhere in that age range our body starts to show the effects of time. We're not the nice, young, healthy 18, 20-year-old anymore. We're now 35. We're out in the workforce. We're having to deal with body mechanics. We're having to deal with the work environment itself, which may not always be conducive to back health, maybe doing some improper mechanics, and maybe even ourselves, we're getting a little out of shape, putting on some extra weight, things like that. So 30 to 40 is actually a protective age range if that first significant episode of back pain shows up. I'm not saying protective that it's not a problem, but it makes it a safe risk time versus if you're under 20-ish and you're having this debilitating back pain, why? 20 and under should have healthy bones and tissues and discs. I need to look for some other problem. Over 60, 65-ish, somewhere in there, what could be going on there? What could have the osteoporosis, compression fractures? Maybe their back pain is actually an aortic aneurysm or dissection. Maybe it is a cancer that's now showing up, things like that. So 30 to 40 is kind of reassuring as far as that first time significant back pain episode. All right. Now looking at the symptoms, the more the symptoms stay close or localized is also safe. The more the symptoms radiate to multiple body areas, that's more concerning too. It could just be a higher level problem, but it's not the safe expectation we normally have. Now, I just looked in the book. Apparently, I took this out of the book. The picture was in the back in the appendix because I condensed some stuff. So if you want to screenshot this or whatever, you can. So it's actually not in the back of the book there. But using this picture to talk about the neurosensory exam for these patients, because we're not talking vascular now, we're talking neuro. So when you look at this dermatome, well, let me back up. If you check someone's vascular system, you check their pulse down here in their foot, it is a safe assumption if you can feel their distal pulses, then all the vascular system above is intact. That's for vascular because it tends to follow a pretty straight line. Look at the dermatomes. The ones that come out here like L4 and 5, they don't come straight down, but they wrap around, and some of them actually end before they get down here. So just because the patient can feel and move their toe or toes does not prove that you've checked their whole sensory system that's coming from their lumbar area, which is the most common back pain area. So what do we do for this? We're going to check multiple places going up both sides, comparing left and right. And you've also got to check the back, because if they've got a sacral nerve root compression, just checking the front doesn't tell you anything. All right, you do not need to memorize these numbers. If you look at the picture, you just have to do multiple places, and a good neuro exam is going to be probably at least 4 or 5 places on the front and a couple, 2 or 3 on the back to be thorough. There's no right or wrong to this, but it's just not as simple as saying if you can move your toe, then everything above it is intact because of how they wrap around there. We also may look at their reflexes for these back pain patients. Again, you do not need to scale this or score it, but you do need to know the best and the worst. All right. The best is a +4. The worst is a 0. Now, that doesn't really mean it's the worst, but what's the highest number and the lowest number? Because the best exam is no matter what the number is it the same on both sides? So even if you're only a 1 on your left knee, your left patella, as long as you're a 1 on the other side, that's actually good. It's when, let's say, your left knee is a 1 and your right knee is a 4, there's this discrepancy between the two sides. That's the concern. So symmetrical, even if it's a low number, is good. Asymmetrical is the bad. Some people, you can't get a reflex out of them. That'd be a 0. And a 0 is not bad, as long as they're both zeros on both sides. So 0 to 4, comparing one side to the other, making sure they're, and generally we say as long as they're within 1 point of each other, it's safe. So we've been talking about not neuro, my neuro lecture, we talk about the central nervous system. Here under musculoskeletal, we're talking the peripheral nerves and the supporting structures like the bones and the discs, you know, possibly a herniated disc with inflammation pressing on that nerve root there, possibly some of the ligaments that support this and the tendons and the muscles being overused or strained or deconditioned. So these are some red flags for that back pain. So these are the high risk things that make you step back and go, this is not just run-of-the-mill back pain. Could there be something else going on here? All right. So there's the age range we talked about. In general, under 20, and this is not written in stone. I think I said 60 a minute ago, but generally somewhere in the 50s, we have to think about things about bone disease, vascular issues, things like that. Again, the take home, 30 to 40 is that safe range. The more widespread the symptoms are, for example, if they're having bilateral sciatica, that's more concerning than if it's just one side. If they're complaining of symptoms more higher up in what we call the saddle area, so not just the perineum. And the reason we're talking about this one is we're looking at the sacral nerves here. So the saddle area is not just the rectal area, but think about where you sit on a horse's saddle. It's when your inner thighs, your groin, your perineum. Okay. So that saddle anesthesia is more concerning for significant sacral compression. No, we're not going to x-ray these unless there's blunt trauma. Okay, because most back pain is not due to blunt forces and broken bones. It's mostly due to deconditioning. And the exam would clearly tell you if they had trauma. All right, and you look at the age range, their body size, their work practices, all those other possible risk factors. So at the end of the day, most of it is just a physical diagnosis, the history, treatment with non-steroidals, steroids, muscle relaxants, maybe some pain medicines, but we do need them moving. All right, they get no more than 2 days of bed rest. On day 2 or day 3, they need to get up and move. Movement encourages healing, encourages blood flow. It reduces likelihood of contractures, weakness, things like that. All right. So, you know, do they get up on day 2 or day 3? Or, I don't know. But the take home is the sooner, the better. They should not be on bed rest for a week. Most patients, I give them 2 days. And I usually give them some significant medicine so that on day 2, there's no excuse they can't get out of the bed. So they can start moving. They may not be healed yet. They should be feeling better. They can start doing some movement and some type of physical therapy, either on their own or sometimes we refer them to physical therapy. All right, some fill in the blanks just to tie some things together here. So let's name one fracture that is commonly seen with compartment syndrome. So how do I answer this? I have to remember back, what body parts most commonly does compartment syndrome happen in? And it most commonly happens in your lower legs, well, any of your legs or your arms. All right, so bones in that area, we got the tib fib, we got the femur, we got the radius, we got the ulna, the humerus. Those are the common areas affected. And of the extremities, it'd be the lower leg and the forearm. Most, because we're usually reaching in somewhere or stepping in somewhere that gets, you know, crushed or mangled or trapped or whatever. What are late signs of compartment syndrome? So remember, it's a buildup of pressure. It affects the lowest system first, and then it goes up from there. So it starts with lymph vessels. Next would be obstructing the veins. And then next would be the arteries. And then the last two, which requires the most pressure, is the movement and the sensation, completely gone. While losing a pulse is going to get all of our attention, it's not the end process yet. You can still get a true paralysis. You can still get a true anesthesia. What would be an initial nursing intervention if we suspect an open wound near a fracture? So we're thinking it's a compound or open fracture is what we're looking at. Our main goal here is to protect that area, cover it, some type of barrier, some type of dressing, sterile. I also say moist. You know they're going to be taking this dressing off multiple times to look at this, and I don't want to be ripping clots off every time they pull the dressing off. So something moist is not going to stick to it. Let's get the x-rays and see if it really is a fracture or not. Remember, I'm only using saline in our compound fractures. I'm not using betadine. I'm not using Surgiscrub, Physoderm, any of those. I'm using saline only because I don't want to run the risk of leaving some irritant in there that I can't get out. Inflammation of the synovial cavity that surrounds or overlies the joint. So we had to draw a distinction between these two areas around the joint. This is around it, or extra-articular. This is the bursa. The bursa is not part of the joint capsule. It's outside of it, but it's the same fluid, and we can get a bursitis just like a joint effusion from overuse, friction, inflammation buildup. It's just that it's outside, and so therefore the swelling is much more definitive when you see it. In general, the time frame for gout onset, and this is a CEN exam, so we're not talking chronic gout, we're talking acute gout, so maybe the first time. In general, that's going to be keywords like sudden, hours, rapid, overnight. Very, very, very quick onset. Chronic gout, they may actually live with that all the time. What two physical assessment techniques did we do for carpal tunnel syndrome? So we had Tennell's, which had a letter T, and I remember I put the wrist in extension, which makes it better, and I tap on the nerve. All those letter T's. Extension, better, tapping on the nerve, Tennell's. Then I had Phelan's, which sounds like a letter F, and I remember I'm flexing the wrist, and to do that, I'm pushing down on the phalanges, which is that Latin word for fingers. And if extension makes it better, flexion will make it worse. What's going to protect immediately? A toxoid or immune globulin? I'm going to key in on one letter, and that's the letter I in immune globulins. They work immediately. They are actually antibodies that you're putting into the patient. Because you're putting the antibodies in there and the immune system is not doing anything for protection, it's just receiving them like, oh, thank you for the gift, I don't have to work. That was your passive vaccination. Immune globulins are passive, toxoids are active. Which patients need tetanus immune globulin? So most of the tetanus shots you give are tetanus toxoid. That's the typical tetanus booster we give in the DTaP or the Tdap or the Adacel. It's the toxoid. This is immune globulin. Many patients don't get this. What's the key letter here? Letter I. I need tetanus to work immediately. So who needs that? Someone who's never had their tetanus shots growing up. They've got no residual active immunity from the toxoids. So I need to they've got a high risk wound, they've got no primary series, I need to give them immune globulin right now to start working today, okay? So we'll do this typically with our unconscious trauma patients that have injuries, because you can't wait to ask them, have you had a tetanus shot before? And just give them the TIG regardless. You're not going to hurt them if they don't need it. You're looking at compartment syndrome. What lab tests might we do? So we don't have a lab test for compartment syndrome. We measure the pressure with that pressure needle. Normal pressure should stay below 20, usually around 10. All right, if it's above 30 or 40, we're saying, yep, fasciotomy possibly. But look at the muscle damage that's probably happened. So we have to worry about rhabdo. So that's where we check the urine for myoglobin. We do the muscle markers like the CK, the CPK, CKMB. Might look at that potassium also, because damaged muscles give off potassium. They can actually get hyperkalemic. So the take home for this, the point of this question is, the only test for this is the pressure measurement, but we have to look for the consequences from that tissue breakdown. All right, what are some things I'm going to rule out with costochondritis? So this person showed up with chest pain, and I have to pick possible things that could be causing it that are treatable. So I have to rule, and we always start with the major life threats. So acute MI, coronary syndrome, ACS, pneumothorax, pneumonia, if they're there coughing up, yucky looking stuff and fevers and chills and all that. Maybe broken ribs even, a high school football player comes in having chest pain, maybe got hit in the ribs, need some rib x-rays, PEs. So costochondritis is a diagnosis of exclusion or diagnosis of rule outs. What age range is a possible red flag for back pain? So this is pretty fresh in your mind. So the red flag is generally under 20 or generally over 50-ish. The safe range is 30 to 40 because it's very expected. Most of us will have one episode at some point in our lives. just due to the wear and tear and the effects of age, generally in that 30 to 40 range. And then number 12, you get to write in. I actually think 12 was supposed to be on the next page, but got chopped off in the editing process, so just write this in. What is the purpose of traction splinting? So remember, the purpose is not to make them feel better, to reduce spasm, to realign things. The purpose, the sole purpose, is to stabilize that fracture site. Now, by doing it correctly, you may get the things like the pain reduction, you may get the less spasms, you may get the comfort and all that, but that's not the point of doing this. We stabilize it, and then sometimes the other good things happen also. All right, we're at the end. I'm sorry I kept you guys a bit longer than I planned. Actually, just FYI, when I looked at my times on these, this is the longest session of the 4 different sessions. And it's just the way